Dr. Pradeep Mohanto has just come. So you were speaking on incisions. So I was to follow with the
No, it doesn't
nuclear
matter, sir.
management. But
Yeah.
anyway, let's proceed the way we are. So essentially, we are going through the basics of SICS, and so this is we need a good incision. I mean, SICS predominantly is an incisional surgery. So the usual is a frown incision, 1.5 millimeters from the limbus. That's the external incision, followed by the corneal tunnel, the scleral tunnel, with the scleral pockets on either side to accommodate the depth of the nucleus, and then the internal corneal valve, and then the internal corneal incision. So 6.5 and a trapezoid 7.5, leading to, this incisional size would vary on the grade and the size of the nucleus. So this can actually very conveniently deliver a 7.5 millimeter by 4 millimeter thick nucleus. Now, usually we use the irrigating vectis. What is done is basically the eye is turned down with the forceps, or maybe a bridal suture in case you are using this. The irrigating vectis then goes below, and it irrigates with the irrigating vectis slightly up, so the internal hydrostatics build up. What This hydrostatics then engages the nucleus in the correctly positioned incision, and then you just depress the posterior lip. The only thing that the surgeon has to do is to depress the posterior lip, and there is some amount of scleral stretching, and the pockets accommodate that, and the nucleus is delivered. At no time do we pull up, because that is one thing, is a strict no-no. Obviously, the advantages of SICS are many, and the incisional stability, sutureless, has to be as good, and we have to check this after every surgery. And as we saw Dr. Saikia giving a suture in one of the cases, now the fundamental thing of this sclerocorneal flap valve incision is that when we lift the upper lip, like when we are doing the rhexis or when we are cleaning the cortex, we close the globe. And when we depress the posterior lip, we actually open the incision, and we can bring out what is necessary. So, this is a wonderful example. Like when you are lifting it, you see the chamber deepens and the pupil enlarges. When you are pressing it, the incision leaks. So, this is a very classical demonstration of the. And the other thing is you need a big rhexis, which is proportionate to the incision on the lens has to be big, and you have to dial out the nucleus through the incision. Now suppose in this case we try and show you that you land up with a small rhexis. Actually this doesn't look all that big and hard cataract, but it is a big cataract. So now with a good hydrodissection, as you see the chambers shallowed, and now we are rotating the nucleus freely, and now we try to prolapse. You just take one part of the equator out of the rhexis and then walk on the equator of the lens. Now it is not happening. This is only because of one reason, that the rhexis is small. The surgeon here is trying desperately to slip the rhexis and get the equator prolapsed. It's not to happen. Any procedures beyond this is risky, because then we'll end up with a dehiscence. Sometimes we make just one cut with scissors, but that's not enough, because if the stretch forces are more, this will extend to the equator. So the better way to do it is to give multiple releases, because by this time you cannot actually do what Rakesh did in the previous case, that enlarge the rexes, because staining is not possible. You've given visco, all the cortex and nucleus is messed up, so the release of the capsulotomy is in multiple points, but this almost behaves as a bag, so it is perfectly right to do so. And now you can see how easily the nucleus will come out. So that's what it is. And now you can actually, prolapsing the nucleus is another part, and the rexis nucleus disproportion is a thing. Now to understand the incision in a cadaveric eye, where is the nucleus getting stuck? In this case, the nucleus is getting stuck in the internal incision. So what we need to do is enlarge the internal incisions. Don't do anything further. Now that we have enlarged we are enlarging the internal incision, and now let's see how we go about it. Now here the nucleus is stuck in the scleral tunnel. That means either the incision is small or the pockets are inadequate. So essentially we have to enlarge them. And then only the nucleus will come out. Now if we go back, so if in this case we just pull the nucleus up in an apprehension to bring the nucleus out, you're just rubbing the endothelium. So all these steps, push back the nucleus and do where the incompatibility lies in the incision. So just to go through a routine vectis delivery. So you need a big rexis, and most of the cases we actually use a PMMA lens, so it is better to have a bigger rexis. Why not a can opener? Because there are tags in the capsule, and when you actually try to do the cortical cleaning, you can catch one of the tags and actually cause vitreous disturbance. So if you can do a cortical cleavage, which is not possible if it is a nuclear cataract, then only it would be possible. It saves on the cortical cleaning time. Now look, the left hand forceps going down, and all that the right hand vectis is doing is pressing the posterior lip. There is nothing else to be done. So essentially, so that cleans up the bag and you can deliver the nucleus. Now another incisional thing is, like if you have a very hard nucleus, now you need a 1.5 millimeter corneal rim, but if you go up to 3 o'clock and 9 o'clock, you can have a very, very big internal incision, and if you dissect a parallelly bigger scleral flap, corneal pockets, then you can deal with a really thick and big nucleus, however hard or big this is. So we will show another video around that. So here we have a very hard and big cataract, which you will subsequently see. Obviously the thing to do it, and when the external incision is done for beginners, you will see that usually the premature entries are in the center, and the buttonholings are in the periphery. Why is it so? Because the globe is curved like this. So we are initially shy with the external incision, so there is less tissue engagement in the periphery and more tissue engagement in the center. So when we go in for this dissection, and obviously this entry into the anterior chamber, the keratome, has to be parallel, because if you are slightly this side or that side, then you will encroach, that side will go towards the, will cross the sclera and the valvular action will be lost. So here, creating a corneal valve all the way down to 3 o'clock is the challenge, that you've got to go like this and create that corneal valve. So just to demonstrate the corneal valve up to that area, and obviously you have to do a big rhexis, and so this is the hardness, and this we just picked it up because it's a nuclear cataract, but the better thing would be to do a hydro and dial the nucleus out. Now you see, because the incision is adequate, such a hard nucleus comes out absolutely easy. So essentially it is about the dynamics of the incision that does the trick most of the time. Now suppose there is another technique which is to bisect the nucleus. Now we started phacoemulsification, but this was too hard for phaco. Patient wanted that. The snare. Now you can go with the snare from below up, and when you have crossed the equator of the lens, you can just turn it and then snip it into two, or you can do the other way around, go above the nucleus and then turn it around, and once you have 2 pieces, 3 pieces, you can actually hold it with a forceps and depress the posterior lip and bring it out, or you can use the irrigating vectis. So in the Blumenthal technique, the whole thing relies on the build-up of the internal hydrostatics through the AC maintainer. You put a sheets glide and just press. That's all you are doing, creating the right area for the nucleus to come out, and you are just pressing on the sheets glide and the nucleus should come out. So the fundamentals of the Blumenthal technique is a wonderful way of doing SICS, because all through, and this is the sandwich technique. My only thing about sandwich is both your hands are engaged. So the third hand instrument, the forceps that we were using, you need a bridal suture if the eye misbehaves. If you are doing it under tropical anesthesia, again a sandwich technique is not a very convenient one. This is the last video, which is 1 minute. I think we have time for this.
Yeah, sure, please carry on.
So this is an envelope capsulotomy and a fast way of doing, Chitrakoot style cataract surgery. This is actually the Lahan style of doing it, except the fish hook, because Chitrakoot does more than 1 lakh cataract surgeries every year in one hospital, between 26 laminar flow theaters. It's a place worth visiting for all of you. You must definitely go and see how efficiently they do the job. This part is unnecessary. What is like 2 Christmas tree thing on the anterior capsule, and then you have the anterior capsule still. You can, I appreciate that, I suppose, and then just hold it with a forceps. Well, here, the surgeon prefers to do it slightly differently. He just holds it with the Simcoe and just gets a rhexis, and now you can put the lens in. So these are the various ways by which you can deliver the nucleus safely. But please understand, this is an incisional surgery, and the incisional dynamics and its proportion and compatibility with the nucleus is the main play. So thank you very much for your attention.
Thank you. It's a really wonderful session, and Dr. Debasish has given already a very good descriptive picture of how to deliver the nucleus. That's the only important part in the SICS. If you can deliver well, you will get the good results. Do you want